Welcome to this week's deep dive. It's been quite a packed 5 days, hasn't it? We've been looking at some, well, really critical areas of ECMO care through our daily vitamins.
Absolutely. Lots of important topics.
So today, the plan is really to take a step back, see how all those different pieces fit together.
Yeah, build that bigger picture. How does prone positioning relate to anticoagulation or fluid balance, tie into weaning? They're all connected.
Exactly. We want to connect those dots, so you can take away a more cohesive understanding for your actual day-to-day practice.
Sounds good. From the mechanics right through to the very human side of things.
Okay, let's kick off where the week started. Monday. Prone positioning. Specifically in VV ECMO.
Right, veno-venous. For lung support, primarily.
And proning, we know it can be great for oxygenation in ARDS, but the focus was on circuit pressures.
Because when you flip someone prone, you're putting pressure on the abdomen, right?
You are, and that can potentially squeeze those big veins of the vena cava, the iliacs.
Which makes it harder for blood to drain back to the ECMO circuit.
Precisely. So you might see changes in your circuit pressures, like higher pre-pump negative pressure, or maybe even drops in flow.
Yeah, and that's a key takeaway. An intervention that helps the lungs might directly affect the machine, so you've got to be watching closely.
Super vigilant. Sudden changes could even mean, a cannula shifted or kinked.
And the ELSO Red Book is really the go-to reference there. It has solid guidance for troubleshooting these pressure issues in prone patients.
So a practical thing for everyone listening, maybe take another look at your own unit's proning protocol. Specifically, how does it address monitoring those circuit pressures?
Good point. Knowing what to look for and what to do about it is key.
Okay, so that was Monday. Then Tuesday, we shifted gears a bit, moved inside the body, looking at anticoagulation.
But with a specific challenge, thrombocytopenia, low platelets.
Right. This is always a bit of a balancing act, isn't it?
Oh, absolutely. A real tightrope walk. You need to stop the circuit from clotting.
Which is obviously critical for ECMO to even work.
But your patient is already at a higher risk of bleeding because their platelet count is down.
So what do? The key seemed to be really close monitoring.
Constant vigilance again, really. Checking ACTs, anti-AZA levels if you use them, and of course those platelet counts very frequently.
The ECMO specialist training manual was mentioned here, emphasizing that it's not one size fits all.
Definitely not. You have to individualize. Think about why the platelets are low. That can affect bleeding risk too.
So it's about a goal-directed approach. Frequent checks, reassessing risk, adjusting the heparin, or maybe even considering alternatives.
Exactly. And having clear team discussions helps. Like what specific platelet count or what signs of bleeding would make us change our anticoagulation plan for this patient.
Having those triggers defined beforehand. Makes sense.
Yeah, it avoids scrambling in the moment.
All right, Wednesday. Weaning. Specifically, weaning from ECMO in patients with ARDS who also have persistent pulmonary hypertension.
Ah, yes, the PPHN complication. That adds quite another layer of difficulty.
Because you're not just worried about the lungs getting better, you're also really focused on the right side of the heart.
Precisely. That high pressure in the pulmonary arteries puts a huge strain on the right ventricle. The RV might struggle even if the lungs are improving.
So weaning them successfully, it takes more than just turning down the ECMO flows.
Much more. It demands a real multidisciplinary approach. You need to assess both the lungs and the heart function very carefully.
And often involves using other therapies alongside, right, like pulmonary vasodilators?
Yes, things like inhaled nitric oxide or epoprostenol to try and lower that pulmonary vascular resistance. And sometimes inotropes to help the right ventricle cope with the load.
The ELSO Red Book, again, provides pretty detailed protocols for weaning, including how to manage this PPHN aspect.
It does. It stresses optimizing everything else too. Ventilator settings, fluid balance, and really tackling any underlying causes of the PPHN if possible.
So the message there is, weaning with PPHN isn't just about the lungs. It's very much a cardiopulmonary challenge. Regular checks of both systems are vital.
Couldn't agree more. Look at your own protocols. How integrated is that cardiac assessment during weaning, especially for these patients?
Good question. Okay, on to Thursday, fluid management, this time in VA ECMO patients.
Veno-arterial, so supporting both heart and lungs.
And the added complication, acute kidney injury, AKI.
Yeah. So you've got a patient on full cardiorespiratory support, and their kidneys aren't working properly. Fluids become incredibly critical.
It's that double-edged sword again, isn't it? Too much fluid.
Worsens pulmonary edema, makes oxygenation harder, potentially strains the heart even more.
But too little fluid.
And you risk underperfusing vital organs, including those already injured kidneys, can make the AKI worse.
So meticulous fluid balance is, well, non-negotiable.
Absolutely non-negotiable. Strict ins and outs, daily weights, the whole picture. You have to track it obsessively.
And often these patients will need renal replacement therapy, right? Like CVVH.
Very often, yes. Continuous therapies are usually preferred to manage the fluid overload and electrolyte chaos gently without causing big hemodynamic swings.
The training manual offers guidance on integrating renal support with ECMO, too.
It does. It covers the practical aspects. But the core principle is a strict fluid protocol, constant monitoring of hemodynamics, urine output, creatinine, everything.
So maybe evaluate how your unit handles daily fluid assessment documentation for these specific VA ECMO patients with AKI. Is it robust enough?
Worth checking. Precision is paramount there.
Okay, and that brought us to Friday. A shift away from the purely physiological or mechanical towards the human side.
Addressing patient and family anxiety during prolonged ECMO.
Which can be, just immense. It's such an overwhelming experience for everyone involved.
Absolutely. The technology is amazing, but it's also intimidating. And the uncertainty is incredibly stressful. The emotional toll is huge.
So the key interventions here aren't drugs or procedures, but communication and support.
Yeah. Exactly. Clear, consistent communication is probably the single most important thing. Keeping families informed, even when there isn't much news, explaining things in understandable terms.
Answering questions patiently, even the same ones sometimes.
Yes, and just providing genuine emotional support, acknowledging how difficult it is, listening.
Using resources like social work, chaplaincy, they're integral parts of the team for this.
They really should be. They offer specialized support that doctors and nurses might not always have the time or specific skills for.
It's about remembering that human-centered care is just as vital as getting the pump speeds right.
Totally. Creating a healing environment involves caring for the person and their family, not just the physiology.
A simple practical step was suggested. Just take a moment to check in, ask a family if they have questions, offer support.
It can make a huge difference, that little bit of proactive connection.
So wrapping this week up, looking back across Monday to Friday, it's clear ECMO care is incredibly multifaceted.
It really is. You've got the mechanics of the circuit, the complexities of physiology like anticoagulation and fluid balance, the challenges of weaning.
And underpinning it all, the absolute need for compassionate, human-centered care for patients and families going through this intense journey.
They're all interconnected. What you do for fluid balance impacts weaning readiness. How you manage anticoagulation affects bleeding risk during procedures like proning. Anxiety can even have physiological effects.
So the thought maybe to carry into the next week is just that. Remember the connections. Think about how decisions in one area ripple across the whole spectrum of care.
Yeah, maintain that broad perspective. Keep observing carefully. Keep thinking critically about the individual patient and keep supporting them and their loved ones. That's how we optimize things.